Good afternoon from Texas. Good evening in the United Kingdom. I'm Dr. Skip Truitt, Director of the Clinical Foundation of Orthopedics, Orthodontics, and Temporomandibular Joint Dysfunction. I'm going to be your host today for the seminar entitled Open Your Eyes. What we're going to do is examine how you, as a general dentist or an orthodontic specialist, can have a significant impact on the lives of children. As you do, this will elevate your practice to a totally different level and allow you to help children at all different levels with airway obstruction, joint dysfunction, malocclusions, and we'll examine all of those in significant detail. Let's begin by looking at a typical class patient. This child was seen by a different orthodontist, and in the process, they decided to start serial extraction. You'll notice that they've removed the lower C's, and in the process, the serous division 2 that's complicated with the microdontic upper lateral incisors is called an even more severe retrusion of the upper incisors, pushing the mandible distally. As a result of this, it compressed both her mandibular condyles, and she started having severe head and neck pain. The parent went back to the doctor, told them that she started to experience the problem after the extractions, and the doctor told her there was no correlation between the removal of the deciduous teeth and the fact that her child started to have the severe head and neck pain. So the parent found another doctor. We examined the child, and in doing so, we realized that she had a number of issues that were going on affecting her joint. First off, she's a severe dental division 2. And when you get into the program with us, while there will be a cephalometric analysis involved in each patient, we'll actually help you reading the analysis. So by reading the analysis, we've determined that the child's upper incisors are quite retroclined, complicated by the microdontic laterals and the extraction of the lower C's, and that's caused a distalizing effect on both of the mandibular condyles. So there's a lot of research in the literature that shows that by age 9, 90% of the craniofacial growth is complete. So there are two ways of viewing this study. One way is to view it as by age 9, there's 10% or less growth with which to deal, so there's not much you can do. And that's not what the study really makes. The study really says that the malocclusion should be corrected as early as possible, that you see 90% of the damage by age 9. So early treatment is essential, and the earlier I can detect a growth pattern in the child and correct it, the more successful the treatment is going to be. So we analyzed the child's cast, realized that the maxilla was underdeveloped both sagittally and transversely, and the appliance of choice was something called an upper 3-directional Swartz. And by turning the various gears in the appliance, we can advance the maxilla in terms of its width and its sagittal length and the dental division. The lower arch was treated with something called a Williams appliance, which is a fixed expander that contains a lingual wire that's loaded against the lower incisors. The wire is loaded prior to eliminating the entrapment of the upper on the lower. That allows for additional anchorage and allows the appliance to distal drive at the same time we're developing transversely. So you can see the significant change that's occurred in the size of the maxilla. You can see the spacing that's occurring as a result of the laterals being microdonic, and they'll have to be temporarily bonded. And then we'll notice in the process, nature has given her a normal growth pattern, and she moved from the class 2 deep bite into a class 1 division 1 with us simply developing the entrapment away from the mandible. So not all patients will do this. Frequently we have to use something called a bionator to do the actual mandibular distraction. But in this case, nature just took over with a normal growth pattern. So the actual treatment time was 6 months actively. Then we used the appliances as retainers for 6 months. And then we're placing a lingual arch on the lower to hold the lower space of Nance. So the patient started a class 2, division 2, deep bite. The end result was a class 1, division 1, correct vertical. You can see the significant change in her facial profile. You'll notice the gummy smile line that she had, indicating the division 2 problem has significantly been reduced. So at this point, we're going to monitor the child's natural growth. This is where we left her, monitoring. You can see she's maturing into the full permanent dentition. And once we're in the full permanent dentition, we'll begin the orthodontic portion of the therapy. So the therapy was divided into two portions: the initial orthopedic treatment, correcting the skeletal discrepancies, and now we're moving into the orthodontic finish. In this case, we're using the Delta Force bracket system. We're in the initial process of level and aligning and torquing. And we'll use a Rickonator appliance inside the Delta Force for the final bite opening and repositioning of the mandible. You can see as we complete the development, she has a normal profile relationship. Her nasal angle relative to her lip angle is balanced. And the final orthodontic finish with the Rickonator. She'll go into functional retainers at this point. 6 months active, full-time, day and night, and then 6 months passively, nighttime only, and then sequencing out at night, 1 night per month. So you notice she has a balanced relationship in terms of the vertical smile axis. Her labial-nasal relationship is excellent. And she continues to grow normally. So that's really the objective of the exercise, is to find a child that's growing pathologically, treat it immediately so it's growing normally, and then just let nature grow normally for the rest of the child's development. And that's basically what the Meredith study pointed out, is early treatment is successful treatment. And you'll notice as she's matured over the years, she's maintained the normal facial balance, her airway is open, her temporomandibular joints are functioning normally. So what we're seeing here is a basic example of early interceptive therapy, addressing the problem as quickly as we identify it, treating the child back to normal, and then letting them grow as a normal patient. The only time we do not do this is if we're dealing with a skeletal class 3, where the growth problem is pathologic. And in that situation, we treat it early, but we retard the growth of the mandible as much as possible. Let the child pass through the final pubital growth, and then we finish the case orthodontically. So there are two different concepts of what you see. One is if the world is flat, there's nothing I can do about the skeletal growth pattern. The other is that the system is very dynamic. And these are the people that I would suggest you get on the internet and read, because they have a position paper that they update every 4 years, and it'd be this year for the next update. And what they do is they stay abreast of all the changes in maxillofacial orthopedics and orthodontics, and they're basically a pediatric group that integrates this into the treatment of children. So there's a great deal of good literature documenting what we're doing as being a legitimate treatment sequence. The problem basically being when you read people like Enlow and Hans, they understand the problem completely. They lack the clinical experience to actually take it and apply it to the patient. So that's a unique scenario in dentistry, and that most of the good research is done by people that really don't have clinical experience, and they're just unable to convey that information in a practical standpoint. So really, we need to look at this situation from the beginning of the child's development. So what we're really saying as we analyze is that the maxilla doesn't just support the teeth, but if we really look at it objectively, it forms a third of the skeletal orbits. So when we develop a maxilla, we change a child's vision. It forms 85% of the floor of the respiratory passage. That's where the major obstruction normally comes when the maxilla is narrow. Forms the lateral wall and medial wall of the ethmoid sinus. I get constriction of the sinuses. That's where I get venous pooling beneath the orbits in my axillary vault. So all of these things are relative to not just the teeth in the maxilla, but the entire growth of the maxilla itself. The maxilla is derived from dermal bone. Dermal bone is principally driven by function, and the two normal functions are proper respiration and proper swallowing. The mandible, on the other hand, is chondral bone, so the two things you inherit genetically are the length of the mandible and the location of the glenoid fossa anterior posteriorly. Obviously, those things are genetically driven. The alveolar process on the mandrel, chondral base, is dermal bone that's functional. So when you develop the lower arch, you're not really developing the width of the chondral base, you're developing the alveolar process on that base. So the two genetic drives are basically class 3 and class 1. Class 2s are nothing more than class 1s that are trapped, so they can't reach their genetic potential. And the objective there is to find the things that trap them, then distract the mandible prepubital that stimulates the epiphyseal growth plate and in turn allows for the normal growth pattern that's genetic. The only exception to that is the class 3 patient. And what we do there is we trap the mandible so it can't attain its class 3 relationship. And by reducing its growth, we can usually avoid the surgical intervention. So we'll look at a young man that has a number of issues. First off, if we look at his head posture, you can see it's out and forward off the axis vertebra. That's a result of him having to mouth breathe due to his airway distress. With the airway obstruction and having postured forward, forces off the center of the axis vertebra. Now he starts to get head and neck pain from muscle splinting. The muscles start to accumulate lactic acid. So the problem being is the child usually goes into a general dental office, gets examined, cavities, fluorides, sealants, bite wing x-rays, and this child really needs help. His mandible's trapped, his airway is obstructed, his temporomandibular joints are not functioning normally, and caries and hygiene is probably about a -10 on the child's priority list as far as health is concerned. Now again, we're going to take the cephalometric tracing, and again, we will help you interpret the tracing until you learn the skill yourself. But basically, I'm looking for the position of the maxilla to see if I need to bring it forward, the length of the maxilla to see if I need to lengthen it, the dental alveolar base on the maxilla to see if it's properly positioned, and then the relationship of the mandible to the maxilla via the anterior cranial base, and all that we'll interpret. So you'll notice we're in the process of developing his maxilla again. This case, because there's no lower arch length loss, we're using a lower Schwartz appliance. So you'll notice as we start the development, the mandible starts a normal growth pattern down and forward. We're starting to acquire room for the teeth. And if you look at the vault, you can see it starting to descend downward. So the major place to look for airway obstruction is in the narrow maxilla. So as we continue to develop with the Schwartz plate, we have to relieve the acrylic in the vault to allow it to descend. Once we have both arches fully developed and the maxilla properly positioned in space, the next step is to distract the mandible down and forward into a class 1 relationship. In the mixed dentition, the best appliance for this is something called a bioneedle appliance. So by taking the construction bite forward to an end-to-end relationship of the incisors, we've actually distracted the mandibular condyles out of the glenoid fossa. The effect on the epiphyseal growth plates prepubital is to stimulate the plates and to get a change in the length of the mandible to its normal relationship. So do you grow mandibles? Not really. Do you allow mandibles to attain their genetic potential by eliminating the entrapment and distracting them? Every time. And when they distract, they grow to the potential and stop. They don't grow into a class 3. And that's another major sticking point in the orthodontic literature. They'll take a repositioning appliance like a bioneedler, put it on a class 1 rhesus monkey, and they can't make the rhesus monkey class 3. So the research assumes that you cannot, the bioneedler will have no effect. Basically, what they just researched was the genetic potential of a class 1 rhesus monkey they could not exceed. So these appliances don't make class 3s. They simply let the patient attain their genetic class 1 relationship. You can see as we're doing this, the vertical dimension is opening, rapidly coming into its class 1 relationship with the anterior cranial base. So as we continue to develop the maxilla with the binator, bringing the mandible forward into the class 1 relationship. So this orthopedic step, or portion, two steps. One, we had to eliminate the entrapment of the maxilla. And then the second point was to distract the mandible down and forward.
Vicky.
This brought us into the class 1 relationship. So I'm sure as we go through the patients, you're going to have a number of questions about the concepts and techniques. So if you'll just simply make a note of them, at the very end of the presentation, we've reserved time for a question and answer session, and we'll answer all the questions that you may have had during the presentation. Notice a significant change that's occurred to the maxilla. You can see the maxilla is fully developed, and the process is descending down out of the vault, opening the airway both vertically and transversely, and that was the child's major airway obstruction.
Vicky can hear him fine.
Arch, we've developed the alveolar process on the mandibular base. We haven't changed the chondral width of the base. And you notice we've brought the mandible from the trap position down and forward into the class 1 relationship. So a number of things start to self-correct. First off, notice that he's breathing through his nose, not his mouth. As that occurs, he elevates his head spontaneously, so the forward head position is a result of the airway obstruction, and trying to alter the posture without altering the airway obstruction first really makes no sense. You notice his planes, his optic plane, and maxillary plane are all paralleling. And even though the child has yet to finish, nature's been pretty kind in delivering a class 1, division 1, correct vertical. It's going to be my treatment objective every single time if I'm not dealing with a skeletal class 3. Create the class 1, division 1, correct vertical. So now that we've seen a couple of patients, what I'd like to do is go back in and talk to you about some very simple mechanical things.
No, they're all hearing you okay.
Rapidly have a significant impact on the patient. One of these is correcting a posterior crossbite. So we'll look at both the dental posterior crossbite and the skeletal posterior crossbite. The dental posterior crossbite we're going to correct with crossbite elastics. They're actually defined as dental units being asymmetrical to the Roman arch, either outstanding or instanding to the arch. And we let the crossbite elastics actually bring the dental units back into their proper relationship. So we'll look at a gentleman that needs arch development, but also has a posterior dental crossbite. So the sequence there, if I have both, I have to correct the posterior dental crossbite first before I develop the arches transversely. The key is to look at each case, and in our particular example, it is the lower molar that's buccally displaced. So when we wear the crossbite elastic from the palatal of the upper to the buccal of the lower, we want only the lower molar to move. The way we control that reciprocal force is to place separating elastics interproximal, mesial and distal, to the teeth that are actually in the dental crossbite. That opens the contact points and allows for the dental movement. Sometimes these elastics are very difficult to place, and in doing so, you can lubricate them with petroleum jelly, and that in turn will make them very easy to position. So sometimes I open only the lower, sometimes the upper, sometimes both arches, depending on which direction the teeth are deflected. Both the crossbite elastics are changed every 12 hours for new ones, and the separating elastics interchanged every 4 weeks until the crossbite's corrected. Looking at another patient, we can see that it is the upper molar that's out of the arch form. So basically what we'll do there is separate the upper, not the lower. Then the elastics can be placed on bands or bonded buttons Just simply, if we put bands on, we have to separate twice, once for the band spacing, and then again according to the tooth that's actually in the dental crossbite. So it usually takes about 90 days for dental crossbites to correct. Going back to our original patient, we have a number of issues. The top picture is the picture I normally start my course 1 with to all beginning doctors, because typically what they see is the blocked out upper left cuspid. What I'm really seeing here is a maxilla that's underdeveloped transversely. It's sagittally short. The dental alveolar base is retroclined, and the position of the maxilla relative to the anterior cranial base is back. As a result of that, it's trapped the mandible. The mandible shifted to the patient's right side, and then finally the upper cuspid erupted, and because of the underdevelopment of the maxilla, it's blocked out. So to the untrained eye, this looks like a first bicuspid extraction case, bringing the dental midline around to the patient's left side, trying to align the lower dental to the upper dental, when the pathology is actually lower skeletal to upper skeletal. So our objective is going to be to fully develop the maxilla and allow the mandible to shift back to its normal relationship. What's also occurring here is the condyle on the patient's right side is distally off the disc. So if we look vertically, let's see what's going on here with the computer. Let's see if I can do it down here. So if we look down on the upper arch, using the buccal force plane as the guide, we can see that the upper molar is on the arch form. Or if we do the same on the lower, using again the buccal force plane as the guide, it's obvious that it's the lower molar that's displaced buccally. So in this situation, we're going to separate the lower molar, not the upper, and then use the crossbite elastics. The objective is to get the lower molar back into the arch form. Now, obviously, each cast has to be analyzed in terms of its width, which again we will do for you initially, but it's based on just measuring the width of the 4 upper incisors and projecting how large the arches should be to accommodate that dentition. Then in the case of this patient, we had to correct the dental crossbite first, then fully develop the maxilla second, and then evaluate the position of the mandible third. So in looking at the before and after treatment, the maxilla was developed with a 3D Swartz. It just couldn't be placed until the dental crossbite was corrected. The only treatment on the lower was correcting the posterior dental crossbite. Then as we developed the maxilla, the mandible was able to rotate back, and so my skeletal midlines are now correct. So the real key is not the mechanical treatment, but to be able to fully understand the problem. And the additional mistake is to assume the top picture is a dental problem where it's actually a severe skeletal orthopedic problem. And likewise, the bottom picture is ready for fixed orthodontic therapy to complete the case. So the key is to understand exactly what you see. Notice the mandible's in its normal relationship. And if we look at the 3 planes, comparing its optic, otic, and maxillary planes, you can see how the right eye that was up, the right ear that was out, and the right side of his maxilla that was canted up has all returned back to normal as a result of correcting the skeletal crossbite. So we'll address skeletal crossbites next because they're one of the most destructive things in the child's growth pattern. So the skeletal posterior crossbite is defined as an underdeveloped maxilla. And sometimes I find a child that has both the skeletal crossbite and the dental crossbite. And when I find that scenario, I correct the dental crossbite first. So the 2 diagnostic keys is to look at the lower skeletal midline to see if it's deviated and to evaluate the physical size of the lower arch. So this child's mandible is shifted to her right side. You can see as the mandible shift, nature responds with elevating the right orbit, externally rotating the right ear, and bringing the right side of the maxilla vertically up. And likewise, as the mandible goes out and around, it makes the class 1 child appear class 3. So the key is to look at the skeletal midline. And in doing so, we can see there's a significant shift towards the class crossbite side. So the basic rule is anytime you see the lower skeletal midline deviated ipsilateral to the crossbite is bilateral, it only appears clinically unilateral. So we need to bilaterally develop the child's maxilla. And in the process, we'll find the right condyle will come back on the disc, and that in turn will align the lower skeletal to the upper skeletal midline. Now, again, it's critical we can examine all the various pathologies. So we'll have a cephalometric analysis on every single patient, no matter how simple it may appear. In this case, we begin with a simple upper 3D Swartz, developing our maxilla first sagittally, then transversely. You can see as we do so, the lower skeletal midline starts to come back towards its normal relationship. That's the right mandibular condyle coming back on the disc, and the left condyle simply orbiting back in the opposite direction. We've got a lot of anterior crowding as a result of the previous underdevelopment of the maxilla. So it's very common to come in with a segmented arch on the upper central incisors and correct that crowding, then remove the segmented arch. So the key is to see what's happening within the temporomandibular joint as far as the skeletal midline is concerned. Notice starting at the top left picture, the condyle is off the disc. Top right picture, as we develop, the condyle comes closer. Bottom left picture, the condyle is closer to normal. And finally, the bottom right picture, everything is back to a normal relationship. So what we've seen there is a typical example of correcting a skeletal posterior crossbite. The key lies in the initial diagnosis. Understanding that the molar relationship is not the upper molar forward on the right, it's rather the lower molar back on the right. Seeing the skeletal midline shift, knowing that the lower arch is needing further development, so there'll be no lower appliance. We'll let it functionally develop as we correct the crossbite. So this child has had nothing more complex than the upper 3D Swartz, and then allowed to grow normally and monitored till they're in the full permanent dentition. So at this point, if there is orthodontic therapy required, this is where we'll do the therapy. So the actual treatment time was under 12 months, and then we just simply monitored her growth until she goes in the full permanent dentition. You can see the shift of her mandible is back to normal, so what appeared to be a class 3 was simply a rotation of the mandible. And irregardless of the posture of the head, you'll notice that the planes have changed back to parallelism. The optic, otic, and maxillary planes are all parallel. And the longer I leave the pathologic growth pattern, called the posterior skeletal crossbite, the more severe the skeletal deformity. Anterior crossbites can also be very detrimental to the patient's growth pattern. It can also cause some pretty severe periodontal disease as well. The basic mechanical rule for correcting an anterior crossbite is to gain the space first before you actually correct the crossbite. So in the example we're going to see here, the space will be attained by developing the arches. So you can see the anterior crossbite is causing a severe periodontal problem. So anytime I see a cleft on a lower incisor, I have to make a differential diagnosis between a labial frenum causing the problem, which this is not, and the trauma on the incisor causing the problem, which this is. The reasons that is so important is they treat just the reverse. The trauma situation, we eliminate the trauma first and reassess the cleft. When the cleft's the result of the frenum, we have to do the surgery first before we move the tooth, or we'll deepen the cleft. So the key is to make that differential diagnosis by stretching the lip. So we'll look at another patient that has the frenum problem. So our patient, it's trauma, top picture. Bottom patient, you can see the cleft blanching at the base of the frenum. It will require the surgery first before the orthodontic movement second. So it's very key we make that differential diagnosis every single time when we see the labial frenum on the central incisor. Going back to basics, we'll examine the cephalometric analysis for all the possible deficiencies. The laboratory will furnish me an analysis as to how much arch development I need in each of the quadrants. And the actual appliance that we used was an upper Swartz and a lower Swartz. And we'll notice as we developed the arches, we created space to correct the lower anterior crossbite. So now we're back in that same scenario. We're going to retain the case actively for 6 months and monitor the child as it grows into the full permanent dentition. And then we'll reassess at that point in terms of doing the additional orthodontic therapy. So the concept is basically to correct the orthopedic problem as early as you can detect it, and then if possible, wait until the full permanent dentition before addressing the dental problem. Again, you can see nature responding with normal facial growth. And we'll notice that the planes are parallel again. So the child's totally back to normal, has a normal airway, normal temporomandibular joint function, normal occlusion. This child is going to have the posterior skeletal crossbite, which is also going to be a skeletal class 3. So we still have to correct the crossbite first before we can address the skeletal class 3 problem. So we're looking at the same basic things. We're comparing the midlines. Again, the midline is shifted ipsilateral to the crossbite, so it's a bilateral problem. We're looking at the size of the lower arch. The size is good, so we'll place a lower retainer. The effect on the condyle on the right side is to be driven back and up. So again, the cephalometric analysis will allow us to determine the exact pathology. Then we begin the treatment sequence, developing the upper out of the crossbite, retaining the lower, simply because the reciprocal force would make the lower too large in this situation. And we can't address the skeletal class 3 problem till we actually have the condyle back on the disc, and then we'll begin the class 3 treatment. So I can see the same things happening clinically. The shift of the mandible changes the molar relationship. So the decision on this patient's right side is it a dental class 2, upper molar forward, or the mandible rotated in the lower molar back, and it's the latter. Once we corrected the crossbite, we've overdeveloped the maxilla to compensate the class 3. Then we'll retain the case at night until the child passes through the final pubital growth. And then once they're through the final pubital growth, we'll finish the case orthodontically. So at 16, she's still growing. What we do is measure her height, and when she can go through a 12-month interval as a late teenager without changing in height, then we can address the class 3 problem and finish the case orthodontically. So we're getting one final overjet to be sure the maxilla is fully developed and the condyles are decompressed. And then once we've done that, we'll finish the case not torquing the lower arch and bring everything forward on the upper. So classic orthodontics will see that child as a surgical case from the very beginning, let the class 3 fully express itself. Maxillofacial wise, we see it as the ability to develop the maxilla, retard the growth of the mandible, and totally avoid the surgery most of the time. And you'll notice class 3 patients will always have a lower skeletal midline deviation. And the reason for that is the asymmetry that's actually in the mandible itself due to the skeletal class 3 growth pattern. So sometimes we'll mask this dentally by doing IPR and moving the teeth where they appear to be aligned. In this case, the mandible is shifted to the child's right side because the left side of the mandible is larger than the right. So we detected the child's class 3 early, got it back to a normal growth pattern, and then prevented overgrowth by retaining at night. This child obviously has massive airway obstruction. You can see his mouth breathing. You can also see the same things happening to his cranial lesions, right eye up, right ear out and back, corner of the mouth on the right side elevated. We can see the same head posture. It's having to go off the axis vertebra to be able to mouth breathe, and that in turn causes all the head and neck pain. So we're dealing with a new situation here called an anterior tongue thrust. So this child from infancy nursed on his back instead of upright. And what that did is forced him to swallow with his facial nerve and the muscles of facial expression, as opposed to the trigeminal nerve and the muscles of mastication. So part of this child's treatment is to change the swallowing reflex back to the trigeminal nerve as part of the overall treatment plan. I still have to address the skeletal crossbite as well. So again, it's critical to know exactly where the deficiency lies. I do that with my cephalometric analysis. My treatment plan is to develop the upper arch and let the lower arch spontaneously develop, and in the process correct the crossbite, and in the process correct the anterior tongue thrust. My Schwartz-Korkhaus measurements tell me exactly how much development I need at the various areas. And you can see this maxilla is extremely deficient anteriorly, over 10 millimeters. That's the cause of his airway obstruction. So you can see as we develop, it's going to, maxilla will descend out of the airway. So I'm changing the airway, the nasal airway, both transversely and vertically. You can see the reciprocal force has developed his lower arch, so he had no lower appliance, only the upper Schwartz plates. We've retrained the tongue thrust. And now that he's in his full permanent dentition, we can address his orthodontic problem. So the anterior tongue thrust is another growth problem that we correct as early as we identify. And you can see the change in its facial relationship as we've corrected the problem. Head posture changes as he can nasal breathe as opposed to mouth breathe. Our final case is going to be a unique case in that this child was seen by the 3 major universities in my area, and the diagnosis was do nothing, start serial extraction, or place lingual retainers. And since none of the 3 universities came up with the same treatment plan, the parents realized that probably none of them really understood the problem. So you can see this child's got a major growth problem. He's also swallowing with his facial nerve. If you look at the right picture, you can see the mentalis. It's been moving, and that's innervated by the facial nerve. So it's awfully difficult as a dentist to look at these 3 pictures and not see the teeth. What I've really got to do, top picture, see the maxilla. The maxilla is totally underdeveloped. It's what's causing all the dental crowding. It's what's causing the skeletal class 2 mandible. It's what's causing the airway obstruction. And that's awfully difficult right at first to see, because the tendency is to start trying to take out teeth to align the dental units, when it's just the reverse problem. I need to develop the arches to acquire the teeth to align the dental units. One way is treating into the pathology. One way is treating out of the pathology. Again, we need all of our treatment goals. We've got to know exactly where we are in terms of the mandible, the maxilla, its length, its position. And as you go through the analysis with us, we will help you read it. We've gone through our first phase of treatment, where we develop the arches, We're in the second phase now, where we're distracting his mandible down and forward. That's the bioneater we saw earlier. And as we get him into the permanent dentition, we can make the ricanator, much like we used on that very first child. It's a fixed bite ramp that allows us to bring the mandible down and forward and super-erupt the posterior teeth. So the real key is really not the mechanics, but to look at the patient and understand the problem. If I see this as a dental problem and start treating teeth back into the pathology, I make the pathology worse. If I see it as a skeletal problem and treat out of the pathology, nature will respond every time. And now we've created a situation where we do need the orthodontic finish. So this child probably should have been treated at about age 5 and eliminated the problem totally earlier. The problem is most dentists will see the child, see nothing but caries, and obviously that's not the significant problem. You can see as we've developed, his facial relationship has returned to normal. He's a class 1. His planes have leveled. And it's just got to be exciting for you as a good doctor to know you can make that type of a change in another patient's life. So most of you are in a position where you can affect thousands of children over the rest of your career. And that's really your obligation at this point, because it's one thing not to see the problem. So ignorance can be bliss. Once you see the problem, you can no longer not treat the problem. You must address the problem. So what I'd like to help you do is to take your practice to another level, and we can certainly do so. I'd like to say thank you from Texas for joining us. I'll give you my personal contact details and then the laboratory details, and then we'll open it for a question and answer session. Well, something just happened here, John. Your slide just went off.
Hi, thank you, Skip. I'll just wait for you to turn your volume back up. Can you hear me now?
Yeah, we can hear you. Mm-hmm.
Fantastic. Firstly, apologies to some of the attendees. I know the sound went a bit quiet during this this webinar, but we've got a number of questions here. So the first question to you, Skip, is from Marzane Snyman. Apologies if I mispronounced that. How do you know if the condyle is off the disc?
How do you know if the condyle's not on the disc?
Yeah.
Okay. There are a number of different ways you can do it. One way is radiographically examining the condyle when the patient's in maximum intercuspation. And that can be done on children. It's just usually easier to see the motion of the mandible and the growth pattern. So basically what will happen is the younger patient opens, the shift will automatically come back to normal, the skeletal midlines. And that's just the child drops into rest position, the entrapment of the maxilla is no longer on the mandible, and the condyle does something called tracking the disc. Now, later on, as the disease progresses, it won't track, and that's where you start to get an audible click when they have an anterior displacement, and then anterior medial displacement. It progresses from there. But to answer the question, you can usually watch the jaw motion to determine when you're on and off the disc.
Fantastic, thank you. Next question is from Moritz Kraus. One of the earlier cases at about 15 minutes ago, was the phase 2 orthodontic treatment really needed in the case with the boy with the dental crossbite on the 36 and the upper orthopedic discrepancy?
Well,
one therapy, the occlusion and tooth position looked fantastic already, and there was improvement obviously to his TMJ and airway.
I think as far as the orthopedics and the TMJ and airway, no. On the other hand, if you really understood what you saw in that patient, the cuspid still needed angulation. All the teeth needed some torque. So the more you learn about the orthodontic aspect of it, the more you realize how most of the time you need to really finish the case orthodontically to get an ideal result. And on the other hand, if I'm satisfied that there's nothing pathologic in the situation and the patient does not want to take the next step with the orthodontics, then that's their child and that's fine. They can make the decision. I always have them sign something that I told them it needed to be finished.
Okay, thank you very much. Well, another question, can a bionator appliance be replaced, can a bionator appliance be replaced with other appliances such as the MyoBrace myofunctional trainer?
The MyoBrace is trying to do the correct thing. It's just difficult to overposition the mandible with a MyoBrace, and that's where you really get the actual distraction that stimulates the epiphyseal growth plate. So there's nothing wrong with the MyoBrace. It's just usually you end up with partial correction.
Okay, thank you very much. And one from Jarida Shahinas. Thank you for the presentation. Using upper acrylic plate with a central expansion screw to develop the maxilla, what if some deciduous teeth start to move? Should I discontinue from using the appliance?
No, the deciduous teeth are really irrelevant other than you don't put an orthodontic force on them. They're simply used as anchor systems for the acrylic appliances, or not just the acrylic appliances. You can use something like a Williams, but the movement of the deciduous teeth is really irrelevant as far as the development of the arches are concerned.
Okay, thank you very much. I think that's it for all the questions on this. The one thing we do need to mention, that we are running a course 1 in London in June. It's from the 21st to the 23rd of June. And course 1 is early Interceptive Orthodontics. So if this is something new to you, please come along and see the full 3-day course where they'll be explained in a lot more detail. For those who attended before, we always do a half-price re-attendance fee. The course fee is $999 normally, but for webinar attendees even, we're doing a 10% discount, so it's $899. Please just drop me an email or jump on the Cephalo website where you can see all the courses. This webinar is being recorded and it will be made available on YouTube or our Facebook page, but I will be dropping an email to everyone that has attended today. So thank you very much for your time for attending, and thank you very much, Dr. Truitt.
My pleasure. Look forward to working with you guys.